Welcome to fabulous Las Vegas, but more importantly, welcome to the 28th Cervical Spine Research Society Instructional Course Lecture. My name is Michael. My name is Jason Savage from the Cleveland Clinic, and I have the pleasure of co-chairing this session with Max Mayoki from University of Louisville.
Thanks, Jason. We have a couple of short talks, and then we'll go into a case debate.
All right, last but not least, Dr. Patel will talk about posterior cervical laminectomy and fusion.
Thanks, guys. Appreciate it. Welcome to the CSRS, to everybody in the room. Appreciate the time, and it's a great session here. Let me see if I can do better than Wellington on this. Already a win. So these are my disclosures. They are relevant to the topic because they do involve spinal implants, and I'm going to show pictures with spinal implants, but I'll be agnostic to the manufacturer. We've already gone over this case a few times. The upside of being last is that I'm going to be the most memorable, so that's really good. But I also don't have to rehash everything that Tom and Wellington does such a great job of covering. I also intentionally went very light on the papers because I knew you guys would present a lot of papers by this point, and the audience might be papered out. So let's stick to like a regular day-to-day kind of conversation. We've talked about this patient's x-rays. We talked about the MRI, and we talked about multi-level involvement, and I'm going to go into more detail. But I think there's probably three things that you want to start with and leave with in the 8 minutes I have left. One is, like any clinical scenario, we want to start with what we know, right? Let's confirm what we know. Let's identify the unknowns in this environment. So let's think about and be really clear and explicit about what we don't know in this case. And then in that balance of what we know and what we don't know, let's agree, right? I think we can all agree, that we're going to ruthlessly strive to be predictable and safe. I think those are goals that we bring to the table with our patients all the time, especially as both Tom and Wellington say, if we care for our patients. These are the basic framework of how we approach clinical problems. So what do we know? We know the individual here that Andy has presented has spondylotic disease, for sure. And we'll go into some more detail there. But what we really know is that the first symptom that Andy mentioned is neck pain. And I will make the assumption that that's the primary symptom. And that's oftentimes what we see in a clinical scenario. We'll see a lot of patients presenting with a primary complaint of neck pain. And so that is what we know. What we also know, as Wellington pointed out, is that laminoplasty is a wonderful operation. And there's certainly conflicting data on whether or not it's effective in the setting of severe neck pain. And you may see statistically significant improvements in VAS neck pain. But we also know that that patient with really severe neck pain is still going to come back complaining about neck pain, right? And I think that's the clinical scenario that we worry about facing. That's a situation that drives us maybe to think twice about laminoplasty in that population. And we know that patients who come back with frequent complaints often then create a lot of headache and heartache for us as surgeons, right? So there's a unpredictability to the outcome with regards to neck pain that in my hands and in my practice eliminates laminoplasty for folks with really severe axial neck pain. So as much as I appreciate Wellington's thoughts on this, I'm going to have to throw his laminoplasty idea into the waste bin, no matter how sad it may make him feel. So sorry, Wellington. I think laminoplasty in the setting of severe neck pain is not something I want in my practice. I don't want to have to deal with those patients, but I'm happy to have them come next door and see you in your office. What we don't know. We don't know the actual cause of compression. I'm going to argue that in this situation, there's some real uncertainties here. We make the assumption at first glance that this is a disc issue, that it's anterior-based spondylotic disease. We know there's a congenital component to the stenosis as well, but we really don't know for sure what that anterior structure is. So if we zoom in, right, if we kind of spread the screen open and zoom in on that area of maximal compression, and we take a really hard look at what is in that ventral canal, my eyes start to identify a few areas that could represent little bony islands. And I'll go back one, if I can. And I'll go forward again one more. So I'm seeing these little potential bony islands on the x-ray, right? And in an ideal world, I would be saying we need a CT scan, but we don't have that data. We have to make a decision with the data we have in front of us. Then I say, okay, well, do those bony islands match these areas of canal compression? And I think if you put that x-ray side by side with the MRI scan, you start to wonder, are these really just soft spondylotic or even spondylotic disc changes, or might they represent more? And that's a real uncertainty in this case in particular that would give me pause as I think about what my surgical plan is going to be. And that pause moment is going to be where we make a decision to go left, to go right. In this case, do we go anteriorly, do we go posteriorly if we're worried about substantially large ossific fragments anteriorly if it's OPLL of some variant. Tom's made the assumption that it's safe, right? That this is a safe pathway anteriorly. These are structures that can be removed without any consequence. And hey, it's Las Vegas, right? We're in a casino. Let's gamble. Let's take a chance. Because what's the worst that can happen, right? Unfortunately, there's a lot that can happen, I think. If you get into the dura, it would be a really unpleasant surprise at the amount of fluid that you then have coming gushing out at you. So I think there is a concern, not to mention then the potential for neurological decline that can occur with that. So despite the fact that in general, ACDF is a very safe surgery, and it is a surgery I enjoy doing, and I think we get great results from it. When in doubt, and again, this is going to make Tom sad, but when in doubt, I think we have to lean towards safety first, and in this situation, take that wonderful surgery and throw it into the rubbish bin as well, right, because of that uncertainty. So what we do know, to summarize back again, we know the patient's myelopathic. I think that came through in the conversation. We know there's a congenital stenosis element to it. I would argue that this patient does not have great sagittal alignment. I would say that they're not kyphotic through the cervical spine, but their global sagittal alignment is not great, especially in somebody with axial neck pain. And we have this ventral uncertainty. We don't really know for sure what's sitting in the ventral canal. And I go back to the discussion about alignment, and we're going to have an ICL session on this, and I think there's some great papers during their annual meeting as well around alignment and how do we start to think about alignment. But we have this general consensus that in patients with degenerative myelopathy, alignment does matter. We have this general idea that we see worse outcomes, both in terms of NDI and MJOA, in the setting of myelopathy. We have some data, at least one of the studies from Chris Ames showed a cutoff of somewhere around 40 millimeters. And obviously there's a spectrum there, but there's some cutoff where you see worse outcomes with a positive sagittal imbalance or a positive C2 plumb line. And then I think if you go back and you look at this patient, I left a slide out, my bad, we have a situation where the patient is quite positive. And in that setting, you've got this wonderful, powerful operation, which is called a posterior cervical fusion, where you can take people with sagittal malalignment and restore alignment, while also decompressing their canal and addressing their myelopathy, and while also avoiding that gusher of clear fluid that Tom bathes in. So what we know that we have in posterior cervical fusion a predictable operation with really durable results, right? We know we have powerful alignment, improvements in alignment, and we're safe. So predictable, powerful, and safe. If those are three adjectives that you like, I think we know where the crown's going to sit at the end of the debate today. So I'll thank you for your time, and we'll go to the discussion.
Any questions from the audience? One thing that you guys didn't really touch upon in all your debates is, do you think there are any differences in C5 palsy rates with the different procedures?
Yeah, so complications, I think it came up a little bit. I know Tom mentioned, or I think maybe Wellington mentioned, that there's this thought that there's an equivalence in C5 palsy rates between anterior and posterior. I don't know that that reflects what I've seen in practice. I think in the setting of corpectomies, you can see C5 palsies, but with ACDFs, are pretty rare. The other component, and if Zoe's in the room, his paper that came out last year suggested a lower complication rate with laminoplasty. And so it may have something to do with mitigating the amount of canal expansion that occurs. But I don't think we have a definitive answer.
Wellington, Tom?
I think the literature is mixed. Personally, I've seen C5 palsies anteriorly and posteriorly with levels in their surgery involving C4-5. But a lot of the literature seems to focus on posteriorly based approaches, but I've seen it anteriorly and posteriorly. Tim, what do you think?
I've got them both anterior. My rate's about 50%.
Wellington says.
What I was going to say, I think it can happen in both, and we have to recognize that. But I think the body of literature suggests, Andy, in the last 10 years that posterior is higher.
Michael Failings from Toronto, no conflicts to report. So I enjoyed the discussion. I think one of the challenges in the interpretation of some of the prior literature, including some that I've contributed, is that we've kind of lumped everybody with degenerative cervical myelopathy together. But the reality is that, we're heading toward personalized management approaches. And I think what's emerging is that if you're going to operate with patients with mild myelopathy, particularly those that have pain, that may influence your decision-making. I can share with you kind of my own thoughts on this, but I'd be interested in all three of you. So let's say that this individual was coming to you with minimal myelopathy, but kind of a lot, kind of neck pain and a lot of arm pain. How would that have influenced your decision-making? Which of those three options do you think would work best in that circumstance?
So I would be the first to say that in that scenario, I'm probably more likely to go anterior because you're moving the pain generator. You're probably trying to get rid of the radicular, component of it. And the myelopathy is not the first and foremost, although you have to treat it, it's not the first and foremost issue. So yeah, I think that changes my sort of view of that.
I think, this guy's got multi-level stenosis, and he's got spondylosis globally throughout his cervical spine. I mean, even if we do a 3-level ACDF on him, we're not going to be able to tell him exactly, well, your pain's not going to be as bad, because this pain may be coming from the cervical thoracic junction, which is going to be left untouched. However, I think in patients who have a preponderance of neck pain, and I don't think that it's radicular, and they have a preponderance of a radiculopathy, I'd go anteriorly, rather than doing a laminoplasty. As Ed Benzel oftentimes says, not all motion's good motion, and in patients who have a lot of degeneration and neck and axially based neck pain, not radicular pain, that pain oftentimes will get better with the fusion and oftentimes can be exacerbated if you maintain that motion at the affected level, surgical level.
Yeah, and I'd maybe build on that and say, Dr. Phalanx, to your point, we tend to lump myelopathy. We also tend to lump neck pain. And I think we've had discussions at CSRS meetings in the past that one neck pain is not the same as another. And so I think we get to the point of where do we think the generator is coming from. And in a setting of radiculopathy, I think we've got data that supports improvements in neck pain when you do surgical intervention for radiculopathy. But in a primary neck pain scenario without substantial neurological involvement, that's a real tough one to feel like we know exactly where the generator of pain is.
Yeah, fair enough. And I guess what I was kind of driving at was that we've done a reanalysis of, the data sets that we previously reported on, kind of from the lens of looking at the mild group, and it does appear that the anterior surgical approach is superior in those
There you go.
patients. Yeah.
Just before you get to Zoe's question, by a show of hands, who here wants to do an anterior procedure? Who wants to do a laminoplasty? Clubhouse leader so far. Who wants to do a laminectomy infusion?
Who's not voting?
Oh, it's over then. It's over.
It's
Powerful.
pretty evenly divided here, so it's a good case for debate. So,
Yeah, just a couple of things. Just to follow up on Wellington's point about the CSM trial, we did see less C5 palsy in the laminoplasty cohort for sure. But at the end of the day, those are small studies. And the question that I wanted to bring forward is that for some of these questions, you need large data sets. And Praveen Mumanini and his QOD group published on neck pain after laminoplasty and laminectomy infusion and showed, I think, quite convincingly that neck pain improves regardless of whether you do a laminoplasty or laminectomy infusion, and they're the same post-op. Large populations of patients, they didn't have flexion and extension radiographs on all of these things, but as the three of you were formulating your arguments, with that kind of data coming out of QOD, how critical is it to really make a decision on the presence or absence of neck pain, not knowing much more about it than that?
From my perspective, I think neck pain is oftentimes, I wouldn't say it's confusing or it's confused within the literature, but I've had patients who have radiculopathy who are younger patients who say they have neck pain, but when you dig into it, as I said in the talk, they have pain over here in the trapezial region. It's referred pain. It's not true facet-related pain. And so in those studies in that registry, as an example, they may not be delineating between that, because I think the only way that you can delineate that is you get a highly selective nerve root block with anesthetic only of 0.3 cc's, or you do an intra-articular facet joint block to see whether or not, what is that, neck pain or is it radicular pain? But from my perspective, I think I don't think that particular study changes how I would approach this. And, as I said, this patient's got a relatively high T1 slope. The patient has a C4, a cervical SVA, which is on the borderline, if you believe Tang's article, but I do think, in patients, and this is just level 5 evidence. In my experience, I think patients who are globally sagittally positive and you do a posteriorly based approach, particularly laminoplasty, I'm not saying they're an overt failure. I just don't think that they have as good as outcomes as somebody whose head is over their pelvis. We're launching a study at the clinic to look at that, so we're getting all, global, the sagittal views. We're getting, in addition to the cervical x-rays to try to elucidate that. But I still don't know. But this is my gestalt.
All right, one last question before we, thanks.
Sure. Greg Schroeder from Rothman. No pertinent disclosures. So Wellington, on your decision algorithm, you had at more than 2 levels to go posterior. I go anterior on 3 levels all the time. Alan goes anterior on 4 levels a hell of a lot of the time. I guess to me, that's kind of the difference, right? I think a 3-level ACDF is much better than a laminoplasty or a lami fusion. But if I have to start getting into 4 and 5, then that's different. So is 2 really the number that you think, or do you think it can kind of change?
So good point. So 2-level, I would do anterior for sure. 4-level, I would do posterior in general. 3-level is sort of like the witching sort of scenario. I think the point to your question is a very important one. How fast you do an anterior operation is a very important factor in outcomes and complications. I'm always trying to evaluate that. What I would have done my first year in practice is different than what I would do now, 15-year. I have no problem going 3-level anterior now as well. But I also think that if you're older and 80 years old, the complication rate is certainly going to be higher anteriorly than it is if you're 50, and so that goes in my algorithm as well.
Perfect. Thanks, man.
All right, thanks, gentlemen. Nice work.